So the APCCC meeting is a consensus meeting. It's not a meeting for new data, but it's really a meeting where we hope to highlight where the data gaps are, I suppose, where the uncertainties lie, and where there are uncertainties, what is to try and establish what may be a consensus approach. So it's actually a meeting which is designed to help us answer those difficult questions that nobody has a clear answer to. My task in this meeting was to give a short presentation around metastatic hormone-sensitive prostate cancer. And the question was, really, are there any patients in whom androgen deprivation therapy alone is still the option? And I think this is, on the one hand, is a fairly easy question, because I think we all see, and where it's documented, there are clearly many patients with newly diagnosed hormone-sensitive metastatic prostate cancer who are not getting additional treatments, be that chemotherapy or androgen receptor targeted therapies. And so clearly there are patients who are not getting those treatments. I guess the question is how can we really identify who they are? And I kind of split this in two ways. The first question is actually, can we actually use biology to predict patients who will not benefit from therapies? In other words, can we predict where these additional therapies are entirely futile? And the answer to that question is that really there's no good biological predictors. There's a fair bit of evidence out there that maybe there are some patients in whom docetaxel is not going to add benefit. And of course, we've kind of known from the CHARTED and the JETUG trials that maybe patients with low burden bone disease may get less, and some of them presumably therefore no benefit from chemotherapy. Of course, there are some controversial data against that coming from the STAMPEDE trial. But there's been a little bit of work done looking at microRNA expression profiling using the CHARTED data set, where you can actually use a molecular predictor which would appear to predict a group of patients in whom chemotherapy is not going to add any benefits. But there's nothing there really that identifies a group of patients who are not going to benefit from additional androgen receptor targeted therapies. So I don't think biology is going to identify that group where no treatment is going to be effective. But of course, the other side of it is what I label as the humanity of it. Additional therapy is not going to add additional benefit. And that's because those patients are not likely to suffer any morbidity from their prostate cancer in the remainder of their natural life expectancy. And I suspect this is the group of patients who are not currently getting these treatments, because actually these are patients who are elderly, comorbid and frail, and actually the prostate cancer is not the dominant cause of the morbidity in the remaining life expectancy. So can we predict who these patients are? Because of course, we can look at life tables. I can tell you that an 85-year-old Scottish man is going to survive on average 5.72 years. And that gives you some flavour as to what that patient's life expectancy, but for prostate cancer might be. But that's only an average. That doesn't really help us answering this. But how can we bring in those comorbidities to better understand the risk from competing morbidities? And I think I highlight that as an area where we probably need to do a little bit more work so that we can be more objective in actually making that assessment that this patient's dominant problems are going to be is heart failure or is respiratory disease, or maybe a combination of the two. And therefore we can accurately predict that this patient is not going to suffer from their prostate cancer if we don't add any additional treatment, and therefore accurately identify a group of patients in whom ADT alone is still the standard of care.